obviously to see the existing data, and this PubMed search in fact consoled me, because if you put in keywords or Chiari-1 and intraoperative monitoring, you get 5 quotations, which 2 of which don't in fact refer to what we're talking about, only 5. And in fact, monitoring of SEPT, these are only 2, and that's part of those 5 above, and 1 just talks about Chiari and acoustic BAER monitoring. However, trying to prepare this presentation, I was helped by the fact that nobody, in fact, mentioned motor vote potentials. I remembered, in fact, that we had an interesting congress in Verona in 2006, and data were presented at that time on this subject. And I think that, in fact, Dr. Millerat was there. Anyway, I think we should go back and see what the indications are for intra-op neurophysiological monitoring. The classic indications is to enable the surgeon to change his strategy so as to avert neurological complications, or if the monitoring is stable, he might be encouraged to be more aggressive if necessary in his surgical maneuvers. And also the idea would be to predict the neurological outcome, to investigate the physiopathology of the neurosurgical diseases and tailor the strategy accordingly, and then also to train young neurosurgeons. And also, this is something that happens in the U.S., but also to provide documentation for medical legal purposes, even if we're rather shy of this in Italy. Now, when is monitoring indicated? Perhaps we could consider it as advisable every time there is neurological complication caused by a physiopathological mechanism that could be prevented by monitoring, for example, intramedullary tumor, or it could be considered optional when it's limited to predicting the outcome or just for research purposes. If we look at the 2 main indications for monitoring, well, there has to be risk of neurological complications. That's a sine qua non. I went to have a look at our Verona data. It's presented at the European Congress in 1999 on a subgroup of Chiari patients with syringomyelia. You can see the symptoms of the patients. As I say, these data are going to be presented by Mr. Ria this evening, and they're updated. You can see the various data and the patient description. Sometime with Matzel, we looked at a subgroup of children, 13% of these, and what came out also has come out already today. These are all complications that can't be prevented by intra-op neurophysiological monitoring. It's not due to a wrong maneuver that can then be remedied during the operation. They're not due to that. This is a wider series from Chicago here to 18% of complications, but again, within the same framework that we mentioned before. However, in 2001, this article came out, Anderson et al., Columbia University of New York, and this is one of the 5 I mentioned before that was cited, 3 from this group, and he sees the somatosensitive evoked potentials that go down in a child operated on when put in prone position. She's operated on for Chiari malformation, and this despite the fact that clinical studies have shown the usefulness of neurological monitoring in the surgery of the spine. As yet there are no data with regard to its usefulness in decompression for Chiari malformations, and also there are no roles which emphasize that monitoring as being necessary when positioning the patient. Here we see the baseline. You can see the cortical responses during flexion of the neck in the position. There is a disappearance of the left median increase in the right, and after operation there's a part to recovery. This girl had a transitory proprioceptive disturbance which resolved after a couple of weeks. So in conclusion, in fact, there is a single report, however, does not establish the need for routine somatosensory evoked potential monitoring in patients undergoing this sort of decompression technique. If we look at the data which were presented 3 years ago at Verona, these are 500 patients. In fact, there was no specification given at the time. These are the proceedings that I got it from. We don't know what patients had syrinx or not, and the percentage of redos. EMG was monitored, motor evoked potentials, and also somatosensory evoked potentials were looked at, and these are the things which are used in most of the monitoring exercises. Reduction of 50% of the stimulus or the result, in fact, is taken as a yardstick, and these patients were operated on in a prone position. There were 32% of changes in SEP. So 1 in 3 had changes in the evoked potentials. It was concluded that in less than 55% was this related to the anesthesia. The correlation with the surgical manipulation was less than 5, as I said before, but in 1 patient out of 4, these altered evoked potentials appeared when related to positioning. This is very important, I think, and perhaps we could discuss this with Professor Millorat about this, because 80% of these patients were repositioned, and therefore the question is, if we don't use monitoring, neurophysiological monitoring, perhaps we are exposing patients to a risk of reduction of their SEPs, and that's a risk we make the patients run in 1 in 4 patients. So perhaps these are particularly at-risk patients. If you look at the reference patterns, they're complex cases that in fact were seen. So we're really talking about a more complex population, in other words. That's one thing. And another thing is we don't know whether extending the SEPs that we use traditionally requires necessarily or is necessarily correlated to neurological problems in the post-op period, because all the patients that we operated on without this monitoring, in fact, don't develop these problems. But anyway, this is a group with a great deal of experience, and I'd be very, very interested to be able to talk with the people directly concerned. This is a young girl that we monitored in Verona. We were a bit frightened by the fact that there was a very tight ramen, and we had an extensive operation, and as we'd only just recently seen this article, we looked for the somatosensitive evoked potentials. There was no significant variation according to the classical criteria on left or right. You can see this. Except here we have a prolongation or elongation both on left and right. This person was operated on in a sitting position, by the way. But anyway, you can see that this resolves after the end of the operation. It seems that transitory factor and we took no action because it was a very slight sign, and the young girl had no after effects. So the question is, does it cause excessive alarm, or is it useful? The other indication for monitoring is that of helping us to understand the physiopathology of due to neurosurgical disease, or the procedure, and helping us to decide on our procedure. Again, this came out 85 with regard to diagnosis and follow-up of Chiari patients operated on. It's consolidated that after some time from surgery, there can be an improvement in the acoustic evoked potentials. Here we have an anticipation of the fifth wave, and therefore the time of conduction through the brain stem is improved. This is a couple of weeks after surgery. However, a couple of weeks ago, this interesting work came out of the Ohio State University, and this is the largest study that has looked at intra-op monitoring in Chiari 1 patients, 80 pediatric patients. Surgical indications were to carry out just decompression and the release of dural bands in patients with syrinx and duroplasty with syrinx, which is the same attitude that we have in Verona for children under ultrasound guide. The BAEPs were monitored throughout the surgery, and the interesting thing is that they divided the patients into two groups. Group A operated on just with bone decompression plus duroplasty. Essentially, these two groups match with the patients with and without syrinx. And the interesting result is that there is a significant improvement in both cases, in both groups, especially in the group with syrinx, of the acoustic evoked percentage after bone decompression. But there's no significant difference between bone decompression and duroplasty. This is confirmed in the analysis between the group and when it's taken when syringomyelia is considered as the main variable. And therefore, the conclusion is that bony decompression improves significantly the conduction time in most pediatric patients with Chiari 1. Duroplasty allowed in 20% of cases only to have further improvement in conduction time of acoustic evoked potentials. Obviously, they conclude saying that the main role of monitoring is that of preventing neurological deficit, and in fact none of its 80 patients had significant worsening of their BAEPs intra-op, which would have led the surgeon to change his surgical strategy. They say quite rightly, however, that it is very difficult with small case figures, numbers, to identify the benefit of a method when the morbidity rate is already very low. So if you want to calculate how many patients are necessary to demonstrate that EP monitoring reduces the risk of paraplegia during spine surgery, well, and reduces it from 2 to 0.5%, you need 860 patients per group. If the risk of deficit of 0 to 0.5, you need 4,674 patients. So obviously a study of this type is highly unlikely to come about. Now, very similar results to the Ohio State Universities was given in 2003 by Anderson, very similar work. These patients had pediatric cases only. You can see in opening the fifth wave, which is anticipated after bony decompression, but there is no modification basically after dural opening. And here too you can see the shortening of the interlatency time, the interpeak time, and bony decompression, and then it stays as it is. Most of the improvement in conduction through the brainstem therefore occurs after decompression, and nothing really very much happens after duroplasty. So one thing is to say that there's an improvement in acoustic evoke potentials, and another thing is to say that this has an impact in the long term. In the Ohio State University study, in fact, the patients operated on with or without duroplasty had an outcome which was matchable from a neurological point of view. Very briefly, by way of conclusions, the techniques available or intra-op, you know that somatosensory evoked potentials are standard method and most often considered for the problem of positioning. You also have to remember that when you have a recording of the somatosensitive, you can just say that the spine and intracranial nerves, etc., conduct properly, but you can't extrapolate specific information on the real motor activity. Obviously, acoustic evoked potentials, especially the latency between the first and the fifth wave. This is an example which comes from surgery of the cerebellar angle. You can see the latency. This was probably due to the positioning of a retractor, and then when you took it away, the evoked potential and went back to normal, or the result went back to normal. So surgical significance of brainstem, cavernous hemangiomas, and operating on these more complex patient or with a Chiari 2 patient, the use of somatosensitive and acoustic evoked potentials allows us to evaluate not more than 20% of the brainstem. Today we have more sophisticated methods, and throughout the surgery we can have the corticospinal monitoring with transcranial electric stimulation and a train of 5 stimuli, or again muscle recording. And also, as we have epidural, we can also look at the corticospinal and also record the T wave, as it's called. Recently, we've tried to extend the principle of motor evoked potential monitoring to the cortical bulbar, not just the corticospinal. Again, it's an electric transcranial stimulus, but the recording is done by inserting electrodes into the muscle, which are innerved by the cranial nerve, the hypoglossus, and the facial, and so on. This is what we do when we attack the fourth ventricle, and this gives us information of all the pathway from the cortex to the periphery. So you can see the latency of this response is much longer than what you get when you deal just with the brainstem. And this sort of monitoring can allow us to specifically control, where necessary, the glossopharynx and the bulb. This is the response which is repeatable and can be carried out throughout the procedure. What we in fact of course the indication is surgery of the brainstem, and it's a good idea, however, to know that it is there, and we can use it also when we have a joint surgery on the joint. This is the left and right hypoglossus monitoring. So we have a deterioration which we see, which meant that we changed the surgical approach, and we then returned and recovered the signal. Again, we can monitor a much wider area of the brainstem. I've got a video to show you. Ecco, qui it's not very focused. This is the corticobulbar, facial, glossopharyngeal, and the left and the right. This is real time, so we have every second an update, left, right, acoustic, somatosensory. So in the space of a couple of seconds, you have all this information on a continual basis. We have to put these forest of electrodes into our patient. And do we have to put in this forest of electrodes? Perhaps we should ask. I think it's honest to say that if you have it available, if you have the economic and human resources available to be able to do that, even if the risk is very low, I think that perhaps we might learn something with regard to positioning if this is important from a clinical point of view, or we can get important information to understand the neurophysiological effect of the various surgical techniques. However, indications for surgery of Chiari, we can only say is really optional. Thank you. Any very quick questions? I don't see any. I agree with your conclusions, because as you quite rightly say, the use of resources is perhaps excessive in surgical procedures which, in fact, if you like, sort of fill certain gaps. And a thing that we have discussed and will continue to discuss is, again, in the case of asymptomatic patients. I mean, let's leave aside intra-op monitoring, but neurophysiological study of these patients before surgery, perhaps. This sort of monitoring could pick up in asymptomatic patients, a cohort which is more at risk, and therefore would encourage us to go to surgery or do something invasive. Quite frankly, as I just looked into intra-op monitoring, and I am a neurosurgeon, I don't have personal experience with regard to SEP or acoustic evoked potentials, studying them in a follow-up or pre-op situation. There is vast literature, and it would seem that the acoustic evoked potentials might well pinpoint distress, which might then indicate surgery. So data exists, but I don't have personal experience in this. Any clinical neurophysiologist would like to take the floor? Physician? I'd like to pick up on that one. Professor Cabuccio asked for the floor before. As it was correlated to what you were saying, well, everything is correlated. I think what's interesting is when you have a basilar involvement as well. You know, when you have those complex situations. You know, when you've got somebody on the operating theatre, in the operating theatre like this. Perhaps in these particular complicated questions and cases, this is indicated. Yes, I think that indication increases with the complexity of the case, and it would be very interesting to hear from colleagues from the Chiari Institute and what they said. It's really incredible. 1/3 of the patient, 1/4 of patients that are repositioned on the basis of the neurophysiological data. So I don't know whether that was a high-risk group. Probably it was a more high-risk group than the group we're used to looking at. But if they do it, I think it has some reason for it. I don't know whether Professor Milorat would like to comment on that. I'm sorry, but there's no mic. Quando Abbiamo parlato qualche anno fa a Verona, abbiamo cominciato soltanto allora la nostra esperienza. Quando abbiamo visto questo degrado nella posizione del prono, andando dal baseline nella posizione supine, non sapevamo effettivamente se avesse qualche significato clinico, ma a New York, che è diventata un quadruolo, diciamo, per questo, è diventato uno standard negli anni 80 di fare il monitoraggio interoperatorio per la dischectomia semplice, e non farlo e avere in 1 in 1000, 1 in 100 complicanze ha reso molto vulnerabile il neurochirurgo. Quindi per la dischectomia anteriore e l'effusione è uno standard della gestione di fare questo. Nella popolazione dei pazienti vari avranno una decompressione e un'invaginazione, e quando mettevamo in posizione il paziente imparavamo dagli elettrofisiologi che c'erano dei cambiamenti, cosa sarebbe successo se non avessimo fatto niente, ma comunque in base a questo abbiamo fatto un riposizionamento alzando le spalle e anche cambiando la posizione del capo. Quindi alla fine penso che un aspetto del monitoraggio che probabilmente non è mai menzionato è il comfort del chirurgo. Se si vede un cambiamento, per esempio, almeno si ha un'opportunità di farci qualcosa. Se questo cambiamento avrebbe causato un danno al paziente non si sa. Posso dire che utilizziamo il monitoraggio EMG dei trapezi, poi anche come funzione del nervo spinale, e quando si fa una riduzione delle tonsille o spostandoli da un lato all'altro. Abbiamo visto qualche attività, abbiamo visto dei picchi di attività EMG, e quindi questo ci indicava di fermarci là e non andare oltre. Se avessimo saputo sapere se poi questo avrebbe poi portato a un danno non si può sapere, però dato il clima che abbiamo almeno a New York, il fatto che la conoscenza è meglio dell'ignoranza e che si possono alterare l'approccio, si può alterare l'approccio riposizionando la spalla, le braccia, eccetera. Allora questo ci aiuta, è diventato uno standard per noi. Secondo me l'alta incidenza dell'ECP nel vostro gruppo è stato cambiato un po' dal pattern di riferimento, cioè casi molto a rischio, molto gravi, ma c'è anche un'evidenza che quando c'è un cambiamento del SEP non è per caso, qualcosa succede. Quell'articolo di Anderson, effettivamente c'era qualche problema proprio accettivo nei pazienti che durava effettivamente 2 settimane. Grazie tanto della sua bella presentazione. I'd like to answer the question with regard to the pre-surgical serial data. Now, we looked at acoustic evoked potentials in Chiari patients with and without syrinx. When we have a complex Chiari patient, in fact, we have alteration of SEP and they correlate with neurological signs. In the patients who are asymptomatic with syrinx, well, we're still analyzing the data, but the trend is that there aren't great alterations of the somatosensory evoked potentials, and probably this is a good starting point to indicate intra-op monitoring that is necessary, which, by the way, we do. Thank you very much.